He's no more now. His son, Dr. Robert Jankelson, follows his footsteps. Bernard Jankelson always said, if it has been measured, it's a fact. If it has not been measured, it's just an opinion. So all the science that is involved in today's talk is all measured. Every EMG is measured, every muscle fiber we are testing, every millimeter is measured, and then only we give a diagnosis and a treatment plan. My teacher in Italy, Dr. Fabio Savastano, he's a practitioner who practices neuromuscular orthodontics in Italy, Albenga. So I was privileged to work with him for some time in 2017, and I had to fine tune my skills under him. He is the one who taught me how to do the myocentric and the jaw tracker, which I'll be discussing. He says there's a new definition for malocclusion according to him, which is that is a malocclusion is any dental occlusion in which a correct function of the tongue and a good neuromuscular relation of the jaws are absent. Today's topic is just to give you an idea of what to expect. What is neuromuscular dentistry? What exactly is it about? How is it related to the TMJ? What is myocentric? What is jaw tracking, which is the company which deals with, it's called Myotronics. How do you manage a orthodontic patient who's in pain, who has a TMJ problem? Then we have latest tools with us in our practice called a T-scan, which is nothing but a digital articulating paper, you could call it. How to use it in orthodontic finishing and management of pain. And in a mixed dentition case, I'm going to show you how do I apply the principles of neuromuscular dentistry. What are these terms? NMD, TMD, OSA. Neuromuscular dentistry is NMD. TMD is your temporomandibular joint disorders. Many patients come to us saying, I have TMJ. So I keep telling them, everybody has a TMJ. You have a TMD. And my partner always keeps teasing that patients comes with TMJ, meaning too much junk. They read on Google and it gives them too much junk. So a lot of myths and issues are there with this TMJ on the internet, which patients gives all sorts of false information to us. OSA, most of my TMJ patients also have sleep apnea. Even in young children, I have patients suffering from 6 years, 7 years of age who come with sleep apnea issues, snoring, migraines. But today I'll be mainly focusing on the TMJ issue because OSA itself is a vast topic. What exactly does the neuromuscular dentistry treat? It addresses the TMJ or muscular problems at a basic level, at a foundation level. That is, it addresses the level of the muscles. How is the muscle responding to every bite, every touch of the tooth? Neuromuscular dentistry is known to treat basic muscles, basic joint, and basic musculoskeletal occlusal signs and symptoms. There is a focus on EMG, which is electromyography. I'm going to show you with cases how we place those electrodes on the patient or the muscles, mainly the masseter and the temporalis, sometimes the digastric and the sternocleidomastoid. So we are going to see that how the EMGs play an important role in diagnosing a problem and of course in treatment. Most of these patients have postural issues, cervical problems. That's why we call it CCMD also. Most TMJ patients in combination with OSA, which is sleep apnea, we call it CCMD, craniocervical mandibular disorders. So it's a plethora of problems that patient comes with. They don't come saying I have only TMJ pain. They have neck pains. They have attrition of teeth. They have breathing issues. They have tight diaphragms, postural issues, forward head posture. So it's a very vast topic to discuss. So today we'll not be discussing about anything related to sleep or posture. I'm going to stick to my talk about TMJ and the facial muscles and how do we treat it in orthodontic practice. Occlusal problems, of course, will be diagnosed and treated in neuromuscular treatment. What is the stomatognatic triad? I'm pretty sure most of us read about this. Joints, muscles, and the teeth. So neuromuscular dentistry, again, make sure that the muscles, the joints, and the teeth have to be treated in unison for a good harmony in the face and the joints. No matter how malpositioned the teeth, the muscle somehow will compensate by overworking or underworking to create a central occlusion. That means most of the load is on the muscles, which is why we say all the craniofacial issues and the TMJ pains are myogenic in origin because of muscles. The changes in the central nervous system is basically caused by abnormal proprioceptive signals. Basically, every time there is, for example, a faulty restoration. So a faulty signal or a faulty proprioceptive input is given from the tooth. So it's highly innervated because of the trigeminal nerve, and the trigeminal nerve, which is the sensory nerve of the craniofacial area, gives a sensory input to the brain, and the muscles are the one which has to compensate and make sure that the teeth bite into centric occlusion. This increased levels of activity is not good. Basically, it causes hyperactivity in the muscles unit, which can manifest itself as noxious parafunctional habits. For example, to avoid a filling, to avoid a high point, the patient may develop into a pseudo class 3. We already read about it in orthodontics. Or to avoid a restoration on the right side, which has a high point, the patient may chew only on the left side. So all these are noxious habits, noxious parafunctional habits, which are developing. It also accounts for the sleep disorders and emotional profiles of many craniomandibular patients. So any faulty sensory input is not good for the patient. The trigeminal nerve, as you all know, 60% of the volume, or how do I put it, the cranial tissue is compromised of the trigeminal nerve. All neural tissue out of the 12 cranial nerves is uniquely associated with the reticular activating center. So you can see how important the trigeminal nerve plays a role. Of course, along with this, the second most important nerve is the facial nerve, which is the motor nerve of the facial area for the muscles of mastication, for their motor movements. So trigeminal nerve, which comprises of 60% of cranial nerve tissue, has an important role in the awakening center of the brain. All sensory information from the teeth, from the occlusion, from the proprioception, whatever you call. Every time there's a contact of the upper and lower teeth, there's a proprioceptive input which is sent through the sensory network to the center of the awakening center of the brain. Struggling muscles are hypertonic, leading to headaches, migraines, shoulder pains, joint issues. We have patients who report to our practice who come with issues of knee pain. Many a times we see that we do small correction in their occlusion, and in a matter of few days they say, whatever instability or pain I had in the knee, I'm feeling better, or my posture has improved. I had neck pain after taking your treatment. My neck feels more stable, and my posture is better. Many patients say, I'm able to breathe better. So what exactly is this connection between the breathing and the sensory inputs and the neck, the migraines? We will see. So it's all myology. Apart from muscles, we also have the fascia, cervical fascia, which play an important role in regulating all these activities. Neuromuscular treatment involves reduction of the noxious stimuli, which is caused by faulty occlusion. Faulty occlusion could be malocclusion, all the classifications that we have, which causes facial and masticating muscles to become hypertonic. Therefore, it is important to relax the struggling hypertonic muscles. In orthodontics, we have a very important article which explains the pitch, roll, and the yaw. If we take an example of an jet airplane or a jet craft, which can move in 3 dimensions, which is the pitch, roll, and yaw. Similarly, it is important we correct the patient's occlusion in transverse, anterior, posterior, and the occlusal aspects. In 3 dimensions also we have to be corrected. We have seen practitioners where we just raise the bite with just an arbitrary number. We have seen general dentists who say, let's raise his bite by 2 millimeters and hope that his TMJ goes away. But how exactly do you derive at that number? What if you're correcting only the pitch or the roll? What about the yaw? You have to make sure that all the 3 zones, which is the mandibular, pitch, roll, and yaw, has to be corrected for the muscles to be happy. Unless the muscles are happy, we won't get the symptoms to come down. Does neuromuscular dentistry has anything to do with occlusion? Absolutely yes. It achieves something called physiologic occlusion. We'll be seeing what is that. Occlusion is maintained by the activities of the masticatory muscles, which are controlled basically by the neural integration. That is the feedback which goes from the occlusion, that is a proprioception, to the awakening center of the brain in the central nervous system. The masticatory muscles which position and connect the mandible to the skull should be the focal point of correct occlusion. So it's not only about teeth, it's about the position of the mandible, position of the skull, the cervical area, and so on. Any of the TMD symptoms can be caused by having the resting position of bites being off than less than a millimeter. What does that mean? as small as a small interference, which is like 0.25 millimeters or 0.3 mm, can cause a cascading event, cascading amount of events to happen. It can cause TMJ problem, it can cause a click, it can cause tinnitus, it can cause vertigo, cause forward head posture, and so on. So it's important that when we do a restoration, for example, speaking in a non-orthodontic perspective, we have to make sure that we do lateral excursions, anterior protrusive movements, etc., and make sure that there's no high point in any of these parts of the mandible. This leads us to search of what is the elusive, the myotrajectory or the myocentric occlusion. Basically, an occlusion derived from the muscles. So whatever we read about centric occlusion, centric relation, technically does not hold good in terms of a patient who has a TMJ problem, because the muscles are not happy in the current position of the patient. And you keep restoring, giving crowns, doing orthodontics, the current position, the muscles are not going to be happy. They are only accommodating. Any accommodating muscle can only cause pain, and in the long term, they can lead to craniocervical mandibular problems. What is this myocentric occlusion? How can we achieve it? That's where neuromuscular dentistry comes into the picture. What exactly is neuromuscular dentistry? How do we do it? What is its objectives? Its objective is to provide occlusal relationships of mandible to maxilla that minimizes need for the muscles accommodate, meaning we bring the teeth into such a good position in relation to the maxilla that the muscles don't have to compensate for the errors in the occlusion. It also provides occlusal relationship that allows normal decompression of neural vascular intracapsular tissue. At the same time, the TMJ, the disc, which is an interstitial disc, has to be improved in position and vascularity, reducing the stress on it. That is, by improving the mandibular relationship, obviously the disc will heal. So we have to reprogram the muscles. That is the objective. So if we have to reprogram the muscles, we have to deprogram them first. So what does this mean? Every time patient is asked to open and close the mouth, there is a memory engraved in the brain, which opens in a particular way and closes in a particular way. So we have to make the patient to unlearn or deprogram this path of opening and closure, and then program it again. So programming again is in our control, is in the muscles which controls it. What is the instrument we use for deprogramming the muscles? We use something called a TENS machine. This is not the TENS which the physiotherapist or any other pain specialist may have. It is patented machine from a company called Myotronics. It is in Seattle. So it's called a J5 Myo monitor. It provides simultaneous bilateral ultra low frequency pulses, electric pulses, which is very, very safe. I have taken it myself. I have done it on small children as well. It's patented for TMJ patients. So this is bilaterally placed. We place 2 electrodes on the coronoid notch, and we subject the patient to 45 minutes of tensing. That's where we place the electrode on the coronoid notch. So bilaterally on the left and the right side. And then we have to give one earthing. For example, any socket, electrical socket, there's an earthing or a neutral. So we have bilaterally on the left and right side on the TMJ, the coronoid area, and then one earthing. And then we start the machine, we switch on the machine there, and then it starts sending pulses every 1.44 seconds. So there are a lot of studies done by Bernard Jackelson, which says that subjecting the patient to this TENS for 45 minutes induces maximum output from a muscle. It makes sure that the muscles reaches its complete deprogrammed state. There are a lot of studies to document this. The mandibular notch is the area which provides a pathway through which the motor trunk of the 7th nerve, which is the facial nerve, and the 5th nerve, which is a trigeminal nerve, as it emerges through the foramen vein. So it's a beautiful location for us to place the electrode and provide the TENS. The best part about this is it is bilateral, it is simultaneous. It's not that it's twitching one side left, one side right. At the same split second, both the left and right sides are getting pulsed at the same time. So it is bilateral and equal. This is a patient who is undergoing TENS. Well, if you can just see this video. Every second you will see that he pulses, he twitches. That's one side, this one side. The others are the EMGs, ignore that. It's only the coronoid notch you have to notice. So this green one here and the black one there is the one which is sending the electrical pulses at 1.44 seconds to deprogram the muscle. It's another important point is he is not biting on his teeth. We have placed cotton rolls in his mouth so that the brain does not know where the mandible is. As soon as you deprogram and you remove the cotton rolls, if a patient starts biting, the memory comes back. So it's important that the patient is disoccluded in the whole process of tensing. The memory has to be removed. Unlike the freely available medical tents which the physiotherapists use, the neuromuscular units are totally patented. It is used only for TMJ patients. It is antidromic. What does this mean? It is not only tensing or deprogramming the muscles, it is also providing stimulus to entire craniofacial area because of the stimulus to the or the closeness of the 7th and the 5th cranial nerve. So entire head and neck area, especially all the muscles which I'll be showing, are getting pulsed and they are deprogrammed. So it's a craniofacial sort of pulsing, you can say. It's important that you pulse for 45 minutes and then all the muscles obtain isotonicity. This is called antidromic effect. So this is just a list of the muscles which you can expect amount of deprogram you can see. So only by placing cotton rolls, which general dental practitioners or orthodontics advise, some sort of Dawson technique, we cannot get such amount of deep deprogramming. Physiology of TENS, basically it works by releasing the lactic acid which is present inside the muscle which is under hypertonicity. So the tensing releases the lactic acid and makes sure that fresh blood enters into the muscles and relaxes the muscles. So basically it's about lactic acid excretion and improving the blood flow. It also relaxes muscles, allows the practitioners to get a muscularly oriented jaw to skull relationship. So the myocentric bite, which I was talking about, or the best deprogrammed bite for the muscles is allowed because of the tensing. In most patients who come with pain, tensing reduces the pain and spasm and tension. It gets the jaw to or the condyle to a particular position in which the disc can repair itself. If you can maintain it in the same position, how do you maintain? Will be seen. Also, like I said, it's important that the teeth are disoccluded to allow any proprioceptive signal. The patient should not touch the teeth during tensing, otherwise the brain gets to know where the mandible is. We are trying to eliminate that memory. Once you finish the tensing, then comes finding out a perfect jaw trajectory, finding out which is the path of closure, where the jaw should be, where is centric occlusion for this patient. More of myocentric occlusion. What is the tool used for that? So we have in our practice something called a K7 evaluation system. It is called the myokinesiography device. So I got to train under this with Dr. Fabio's clinic in Italy in 2017. And since then, I haven't looked back. There's no comparison to handling TMJ patients with any other tool apart from this. You'll see why. So what is this K7? What is this myokinesiography? Anything which can track the movement of the jaw, like a jaw tracker. It's like you have your GPS, every time you switch it on, the phone is tracked through satellite. Similarly, every time the patient opens and closes, you get a graph here, like you can see in the lower right side. This long line that you're seeing is the opening and closing. So this is tap, open, tap, open, tap. Okay, so this is the protrusive border of the upper central incisor. So lower central incisor, opening, closing, opening, closing. A small magnet is placed just behind the lower central incisor so that we can record this. How exactly we do this? I'll just show you a small video. What is the purpose of doing all this sophisticated software? Even though it looks very sophisticated, it is beautiful and amazing tool. It allows the dynamic study of the action of the mandible. It helps in identification of various TMJ anomalies. It helps in recording a precise relationship and helps us in getting something called neuromuscular bite registration. The first section in this will be the placement of the electrodes. Electrodes are those stickers which you see go onto the different muscles. So what are the muscles we are targeting? The temporalis muscle, the masseters, sternocleidomastoid, and just below the chin is the digastrics. So these are the nerves which are easily palpable for us before starting the case. And in most patients, most of these muscles are they show symptoms of pain. When you palpate during your diagnostic stage, they show some sort of pain. And this is the earthing of the neutron. So once all the electrodes are placed, We are going to connect them to the K7 software through wires. And then every time patient opens and closes, you will see that you will get a drawing on the graph. So that's called the EMG, electromyography. Sorry. So the EMG shows two temporalis muscles, L and R, right and left, two masseter muscles, two sternocleidomastoids, and two digastrics. And this is just a graphic representation of the muscles which you're showing to make you understand. So every time patient is connected to the computer, immediately we starts getting readings like this. Let me just play it from beginning. Sorry, just give me a moment. Yeah, you can see there the electrodes are placed. We connect it to the computer, which is the K7 software. And as soon as it's plugged in, you will see that the muscle starts giving us readings. So we have different scans in the scan 3, scan 5, scan 9, scan 11, which all do different works. Basically, it's recording the action potential of the muscles. So normally it should be less than 2. You can see in this patient, it's almost around 2. There's certain other scans. For example, it shows us how much bite force is available in the masseter. So every time he bites, you can see that the muscles fire. Then we place cotton rolls, mimicking food. So every time he bites on food, we can see that he requires more force to bite. So this is a scan which shows bite force. So immediately many scans are there. Once we record the EMGs, then we also record the clenching. When the patient clenches, how is the muscle behaving? So all these have certain parameters which helps us in diagnosing the tonicity of the muscles. Is it hypertonic? Is it isotonic? Is it normal? Is it fatigue? Just after this, we place a magnet there. You can see just behind the lower incisor, and then we place something called a sensor array. So this is the setup we use for a myokinesiography. When this is all set up, we are ready to do something called a jaw tracking. What is a jaw tracking? Once the magnet is placed, sensor array is ready. Every time patient opens and closes, you will see on the left upper side, you have a frontal view of a central incisor upper, lower central incisor, and a lateral view, sagittal view and a frontal view. So you will see that every time he opens and closes, there is a graphic which moves, shows the opening, closing. So advantage is, in this patient, you can see whatever opening is the green, closing is the red color. So every time he opens, it is deviating to the left, closing. So in this patient, mostly the occlusion is, or the mandible is moving to the left when he opens and closes. This is the velocity. So basically, it's giving us the velocity, anteroposterior and sagittal movement. This is a side view. Basically, you can see when he is opening is the blue line, when he's closing is the red line. So mandible comes little forward as he is closing. So it's quite simple, even though it looks too sophisticated. So this is one scan. It's called a scan 2. So all this is done before we do the tensing. Then we have certain other scans which shows us the freeway space. We just ask the patient to bite in centric and do tap tap. You can see every time he does that, the muscle fires, the masseter, the temporalis. And then we have certain parameters to say its freeway space is around 1.4 millimeters. Then we ask the patient to do a swallowing test. Every time he swallows, we'll see the amount of deviation that the mandible takes. So in this, it's not much. So it is within normal range. We also do a scan 13, which shows lateral movements of the mandible. You can see there in the frontal view, the patient can move that much to the left, that much to the right. And then in the lateral view, which is the sagittal view, the amount of opening and the path of closure. So this is the beautiful scans that we get in the myokinesiography, which is the K7 software. So after seeing these scans, we know that it is called as a jaw tracker. There are several scans, like I said, scan 1 to 22, depending on what sort of data you need. But basically, we make sure that we measure the EMGs, we see the path of closure opening and the amount of tonicity in the muscles. It helps us register something called a myocentric bite. We know the path of closure of the mandible. There is some calculation which the software takes, tells us based on a lot of studies that this much of vertical or the clearance is required of the myo trajectory. We have something called a scan 5. What is the purpose of doing all this? We record something called a myocentric bite to make something called an orthotic. What is an orthotic? It is something which the patient wears, what in layman term we call a splint. But anything which displaces the jaw is called an orthotic. So this is a patient example. You can see there. There's 8-channel electrodes placed with EMG recordings. As soon as we plug it in, the muscles start giving us readings. We need to interpret the scans and record our data. So we do this scans before we tense the patient and after we tense the patient. All muscles which are shooting high, normally after tensing for 45 minutes, will show a relaxed musculature. I'll show you in the patients that follow later. What are the muscles we are tensing and checking EMGs? The temporalis, the masseter, the sternocleidomastoid, and the digastric. Instead of digastric, some doctors choose to do the trapezius also. It's up to their wish. So once we know that what is the correct path of closure that the muscles want, so in the myo trajectory, we record the bite. We record the bite, send it to a lab. This is how we are doing. You can see that. I was just doing on a patient. We record the bite with addition silicone with a 2-step putty or a single-step putty or a bite registration paste sometimes. So we make sure that the patient is closing in the myo trajectory when I am. What is this closing in the myo trajectory mean? Let's say there's an overjet of 8 millimeters in a class 2 patient and all the muscles are very hypertonic. When we do tensing sometimes and we check the myo trajectory, the overjet will be only 3 millimeters. So that means the mandible basically wants to come forward and downward. In most patients, in class 2 patients especially, who are in severe high tonicity of muscles, the mandible tends to come forward and downward during tensing. So which is why what we record, only thing we are recording in 3 dimensions, the pitch, roll, and the yaw. That's the beauty. So this is called a scan 5. So this particular patient, this dark blue zone here is the tensing. Every time he's tensing, he pulses like that. You can see there, pulses, it twitches. And then when I ask him to open and close, this is his opening and closing. That is a centric occlusion of the central incisor. Is opening and closing, and this is his myo trajectory. So basically, we derive the path of closure and where exactly the mandible wants to be in 3 dimensions in this particular scan. At the same time, you can see the bar which is showing the muscle readings, whether the muscle is particularly comfortable in that region, and every square in this graph is 1/10 of a millimeter. So it is that precise. What exactly we do with this bite? Once you're recorded, you've done all the readings, you've got the EMGs, you recorded the myocentric bite and the myo trajectory, basically got a clearance in the articulator. You mount it regularly. How you don't need a fully adjustable articulator for this because you already corrected the bite in all the 3 planes. And then the lab fabricates something called an anatomic orthotic. What is an anatomic orthotic? It's designed like cusps and fossa, like the teeth. We also have choices of a tooth colored and a acrylic depending on the needs of the patient. Basically, this is a patient you can see there wearing a orthotic. So patient has to wear this orthotic all the time, even while eating. So that is his teeth. So basically, we are deprograming the muscles by making him bite into a new bite. How do we know it's correct? We have checked the muscles. The muscles are comfortable in this particular position with all the EMG readings that we took. So the first phase of treatment involved in this is a dental orthotic. It's called a splint in layman terms. We call it an orthotic because it corrects the pitch, roll, and the yaw. Orthotic allows jaw to close in more physiological and balanced position. It works like a sunglass, meaning only if you wear it, they work. It's important the muscles are maintained in this function or this functional position so that they are under less strain. At least 3 to 6 months of orthotic wear is recommended. What happens next? After the orthotic wear, some patients may wish not to do orthodontics, which is a phase 2. They continue to wear the orthotic till it lasts, and they come back and repeat in 2 to 3 years. Some doctors choose to do a restorative procedure like crown buildups, which I'm not going to talk today. I'm going to speak about the orthodontic perspective. What exactly is this orthodontics? Before we go jump in and start any ortho for a phase 2 neuromuscular patient who's worn the orthotic for a few months, we have to check for airway obstructions, allergies, tongue function, any adenoids, tonsils, etc., supraerupted wisdom teeth, all these have to be eliminated before we move ahead. Check with all the radiographs, CBCT of TMJ, make sure everything is fine, no bone resorptions, no other pathologies. A complete series of scans can be done again to make sure that the patient is biting in the my trajectory, and then, of course, the photographs. So this is my teacher, Dr. Fabio Savastano, and I did my fellowship with him in Italy. What exactly is this neuromuscular orthodontics? What are the steps involved? The first step is, of course, strapping the upper jaw. Please note that I have shown a picture where only the upper arch has been bonded. So this is a normal situation. We bond only the upper arch, and then we trim the orthotic which the patient was wearing here. I'm sorry, let's go back a few slides. The orthotic is cut, excuse me, distal to the secondary molar. That means he's biting only canine to canine, or sometimes first premolar to premolar, and the posteriors are disoccluded. And then once the posteriors are disoccluded, there's no occlusion on the posteriors on both the sides. We give the patient elastics and we bond only the molars. In this picture, the 6, 5, and 4 is bonded. Normally, I bond only the or band only the 6 and supraerupt only the 6. So step 1 is supraerupt of the posteriors by partial orthodontics in the lower and fully bonded appliance in the upper arch. Step 2 is, you can see there, the posteriors have been supraerupted bilaterally, and then now the patient stops wearing the orthotic, and now you bond the lower anteriors and supraerupt the same. So it's conventional orthodontics, but focus is on supraeruption into the physiologic or the myocentric position that we have derived. The interesting part is sometimes the space on the right is 3 millimeters and space on the left will be 5 millimeters. So that's where your muscles want to be. It's not like we supraerupt equal on both the left, right. It's determined by how much your orthotic thickness was there previously. So this is called verticalization, or what we call supraeruption with slow gentle forces. Step 3, like I said, is finishing the case by bonding the lower and supraerupting the lower anteriors as well. Now it becomes like a conventional orthodontic case where we do the finishing and expansion of the arches, leveling, annealing, and going to heavy wires and torquing the teeth. Then in some patients, not all cases, the patient may give minor complaints of pain in certain movements of teeth. Maybe it is because of the occlusal irregularities that has happened during supraeruption. We have to use T-scan, but in 90% of cases, we will not require it. So this T-scan is a device where you can have a digital sensor. So when I make the patient bite on this digital sensor, we get a digital display of the occlusal forces. It's like a digital articulating paper, you can say. So I'll show you in a patient how exactly I applied it for fine-tuning the occlusion and relieving the craniofacial pain. Step 5, not exactly a step. Debond the patient, send him home because you checked all the EMGs, you checked all the occlusion. You don't need to give any retainers. So absolutely, I haven't given any retainers to most of my TMJ patients once they finish their orthodontic treatment till date, because you have eliminated all the causes, which is the muscles. So you've given more room to the tongue, eliminated all the noxious signals which is coming from the teeth, eliminated all the unwanted muscular forces that is coming from the craniofacial area or the muscles of the head and neck area. Moving on to the cases. My first case is a patient who's a 37-year-old male who had issues of craniofacial pain. He had undergone splint therapy. The doctor had given him a lower posterior splint bilateral, which did not cover the lower anteriors. Basically, he gave history of TMJ pain and headaches. He wore a splint for several months but did not find any relief, because of which there was a bit of posterior disocclusion, but there was no pain relief in this patient. You can see there, the posteriors have been disoccluded because already wearing a splint given by another dentist, but it wasn't helping. So I did a EMG reading for this patient. So you can see all that graphs that is there is all shooting high. So what exactly that does mean? It means that the temporalis, right and left, the mesetas, right and left, sternocleidomastoid, and the digastrics, all are giving a reading of more than 2. You can see it's 4.3, 4.2, 2.6, 3.1, etc. So normally a good isotonic muscle should have a reading which is like 2. So it shows that they are all hypertonic or hyperactive. So it was required that the patient requires all the muscles to be checked and got them into myocentric occlusion. How do we do it? We did his scans. So this was his scan, which showed that when he opens and closes in the lateral view, he could open only 24 millimeters, and there was a velocity which was not very great. Frontal view, again, you can see is going more to the left. These are all preoperative scans. When I did a myotrajectory scan, which shows path of closure, this was where he was pulsing when I tensed him. And when he opens and closes, his mandible was going forward and backward, forward and backward. And in the anteroposterior region, it was moving to more to the right. So basically, the muscles had chosen a different path of opening and closure than where it wanted to be due to some occlusal disturbances or past history of bad treatment. So we gave an orthotic. In this case, you can see it's a tooth colored orthotic. He wore it for several months, and you can see there's a quite vertically quite a tall orthotic. So you could see that probably the occlusal height was clearance was or displacement was more than 5 to 6 millimeters in this patient. So as soon as he start wearing the orthotic, he showed great improvement in the signs and symptoms. He wore it for a few months and he has used it even for eating. So ortho treatment commenced after 6 months, only after we made sure that his symptoms were fine, his TMJ pains was gone and his headaches were gone. So like I said, the phase 1 is the orthotic, phase 2 is the orthodontics. In this case, I used the Damon Clear self-ligating braces. It was particular about aesthetics. There's no particular system that you can use, but if you want better and faster movement, a Damon is good. And if you want aesthetic, Damon Clear is better. So you can see I have posteriorly sliced the orthotic. Previously, you can see the orthotic which was covering the molars and the premolars, I have cut them. So he's biting basically only from 5 to 5, which is the lower second premolar to second premolar. And then what do? We give vertical elastics. In this case, it was 3 by 16 red elastics. I should have given tooth colored. I think we changed it later. The important thing is, I don't know if you can see here, the elastic is placed on the lingual aspect as well. So it's a bilateral supraeruption. So verticalization is taking place from buccal and the lingual aspects. How much is the movement? You're going to do it. So you can see on the left side, patient's left, I would assume it's around 4 millimeters, but it is much more, maybe 5 to 6 millimeters on the patient's right. So it is the pitch and the roll, like I said, need not be equal on the right and the left. That's where the muscles want to be. That's where his muscles told us, I'm comfortable with this position of the jaw. So we went on after the patient continued to wear elastics. I would say him once in 45 days. I want that eruption to happen. After 3 months of time, you can see the molar has lifted. Continue, go to heavier wires in the upper arch because you're also leveling, aligning the upper arch. You don't want too much of the upper to come down. If it comes down a bit, it's not an issue because ultimately you just want to close the gap. Next step is to get the second premolar into position. Again, once the molar has lifted, I cut the orthotic or the splint just distal to the first premolar on both sides. So it's biting basically on front 8 teeth now. It's biting on 10, now 8 teeth. So once the molar, I get a bit of contact, I cut the orthotic, I strap or the bond the bracket on the second premolar, and now patient wears elastic for the second premolar as well. In most cases, I don't have to do supraeruption by putting a button on the lingual aspect of second premolar. Sometimes if it tilts too much lingually, I have to do it on the lingual aspect as well. After posterior supraeruption, you can see there bilaterally, I was able to get a decent amount of supraeruption. The beautiful thing about this is I haven't done anything with the sevenths, the second molar, but you can see the passive eruption. Just in 3 to 6 months, the 7, which was not contacting at all, if I just go back in time, see, there's no contact, has just passively supraerupted because there is no erroneous forces from the muscles, from the buccinator or the masseter. the 7 is just supra into position. After the lower arch is bonded, when do you get a decent contact, a good decent occlusion on both the posterior sides, you then make sure the patient doesn't have any symptoms and you stop the orthotic wear. Now you can see the amount of verticalization that has happened. You get an open bite in the anteriors. Now what is left to do? Just have to treat it like a normal open bite case. Strap the lower anteriors and start supra-eruption. You can use any conventional box elastic or a triangle elastic or whatever is comfortable. Don't have to do any complicated mechanics. So patient wears elastic. I usually give a triangular elastics from canine to premolar canine on both the sides. At the same time, we can see as the upper level, you start getting spaces which can be closed with E-chains later. Once the posterior supra-eruption happened, I get a decent occlusion. Now it's like a conventional orthodontic case. I have got the jaw, I have got the teeth into the position that the muscles want it to be. And then I finish leveling, aligning. It's important that in most of these patients, they have history of sleep apnea and they have parafunctional habits. I have to give the tongue more space. Otherwise, it's not going to help them in the sleep apnea. So when I give the tongue more space, I used FRLA. What is this? It's a fixed removable lingual arch. You can see there. A slightly over expanded arch. I force it in and I place it on the lingual sheath that is welded on the molars. At the same time, I am continuing my space closure on the buccal side. So once I get a decent amount of expansion, sometimes 2 to 2.5 mm, I just make sure that the molars have not flared buccally, or I go to a heavy wire, 21-25 in most cases, and then both lower and upper, I get decent amount of expansion. So basically, I'm creating more room for the tongue while maintaining the occlusion in the myocentric position. Before debonding, again, it's important to make sure that the patient is asymptomatic. But since I cannot take a risk, I have to do the EMGs and scans prior to debonding. So we take the patient to the K7, the EMGs, and before tensing this, I just connect the electrodes and see that there is readings of the temporalis masseter, digastric acericomestet. Most of them are showing less than 2 millimeters or just around that, which is great for me. That means he doesn't require any muscular corrections, and he's not, definitely he is giving me history of absolutely no pain or symptoms in TMJ. He's able to chew food, etc. And opening closing, which was 24 mm initially, increased to 34 without doing any treatments. You can see it's almost similar, but still there was some amount of deviation to the left. His mandible wanted to be there. In the scan 5, which I said the myocentric trajectory and the myocentric pulse have to match. You can see the dark blue zone there. So he's opening and closing in the same pulse that the jaw twitches during tensing. So when you connect the patient to the electric tense, he twitches in this zone. And when he opens and closes, he's also in the same myo trajectory. So the myocentric point and the myo trajectory, if it is almost the same, it means that the patient's goal have been achieved, objectives have been achieved. Again, in the frontal view, you can see he's almost opening in the center. This is the center, slightly to the left, it's okay. So you can see a comparison of the pre-treatment OPG before we started any treatment at all, and then after orthodontics and after doing all the treatment, settling the occlusion, you can see most of his EMGs have relaxed. That is this treatment. Once I debonded, slight, because of the band, there was a slight contact there. You can see a small space. He required is there's a crown on the upper left secondary wall which has to be replaced, but otherwise was able to get a decent midline and a decent occlusion. Most important for me is he did not come back for almost 2 to 3 years with any symptoms. I did do a regular follow-up, but for 2 years, most important again, I forgot to mention, I haven't given any retainers, which is the success for me. I took an OPG just to make sure. It's very difficult in most of our practices to take x-rays like we do in a PC time, but somehow I was able to convince the patient and do an OPG. You can see that I was able to get decent amount of root parallelism. This is post-treatment and without much of resorption of the roots. And I saw the patient again. I think it was almost 3 years since I debonded him. He's absolutely asymptomatic. Absolutely no retainers were given. So we move on. to a patient where I integrated T-scan. What is this T-scan? Like I said, it's a digital articulating paper, which I can use in my armamentarium to fine tune my orthodontic cases. So again, it's a patient who had well-aligned arches, but he had history of TMJ pain. Another dentist gave him a splint, but he said his migraines did not go. He had a little bit of clicking and TMJ pain. He also had a mild OSA patient. We do sleep studies of PSG3 for most of these patients, and he showed signs of clenching at night, night bruxism, because he had mild sleep apnea. So even after doing a splint, you can see slight distal occlusion in the posteriors again. His arches are well aligned, but you can see good amount of occlusal attrition in this patient. So I took him up on the EMGs, and I checked on his scan that there was a little bit of deviation during opening and closing. It was not in the same trajectory. 37 mm of opening was there. So something not right. So when I did his pre-tense EMG, before tensing him, it was giving very high readings. And then 45 minutes of tensing was done for this patient. And all the muscles, which are very, very hypertonic, just relaxed. You can see 22, 15, 70. Sometimes when earthing is also a problem, we did recheck it twice, but his muscles were really, really stiff and hypertonic. You can see post-treatment, the muscles, post-tensing, sorry, I haven't started any treatment. The muscle just deprogrammed and relaxed. So we gave him an orthotic in the front. He did not want it to be visible, so we cut it in the anteriors. But you can see he was a chronic smoker. He just stained the orthotic very soon. But the amount of vertical clearance you can see there, it's disoccluded by more than 4 to 5 millimeters bilaterally. That's where his jaw tracker showed that the jaw has to be in this position for him to be comfortable. After orthotic wear for a few months, his mouth opening improved to 40 millimeters, and the path of opening and closure, which is opening is green, closing is red, is almost the same now. And this is a velocity to improve. Basically, mouth opening improved, opening path of opening and closure improved. 6 months he wore the orthotic, he came back. We decided to check his symptoms. He was asymptomatic. We strapped him up for the phase 2 orthodontics. So you can see your scan 2 comparison. Scan 2 is the opening and closing. 37 amount of opening of mouth in the beginning. After wearing orthotic for 6 months, 40 millimeters. Some other scans. So I decided, since he was asymptomatic, to go ahead and strap him up for the orthodontic treatment. So I bonded his upper arch with Damon self-ligating Damon clear braces. Started with 016 arch wire, and like I said, by then he had, since he didn't have anterior coverage of the splint in the anteriors, when I trimmed, hardly any splint or the orthotic was left, but he somehow managed. You can still see the teeth marks on there. That means he bites exactly. So I have given him a canine and premolar guided bite. So maintaining the occlusion, which was there previously here, I'm sorry. And then since I cut it posteriorly, now it is time for the supra-eruption of the posterior. So we start lifting the molar one by one. Again, you can see the sevens are disoccluded. I haven't done anything for the sevens. Once the supra-eruption of 6 is done, I do the 5, you can see there. And then once I get satisfactory occlusion, in 7, 6, and 5, you can see a 7 is almost there. 6 is occlusion. You can see the supra-eruption that's happened. In most of these patients, even though it looks like so much of supra-eruption, I've never got a case where there's any mobility of tooth or there's any cervical abrasions which is happening because of supra-eruption. Most patients are asymptomatic. And because the physiology is taken care of, the muscles are taken care of, they are happy. So you can see there, once I get posterior supra-eruption, I ask the patient to stop wearing the lower orthotic and I strap the lower anteriors and I start supra-eruption of the lower anteriors. So then, since he had well expanded arches, I didn't have to expand too much. And then maintain the midline. Poor oral hygiene, you can see there since he was a smoker. But I was able to get a decent amount of occlusion. And then just before debonding, made sure he's asymptomatic, check his EFGs. Almost okay. Between 2 to 3. Again, like I said, we have to get some amount of expansion. whenever possible in most of these patients to correct sleep apnea, to give more room for the tongue. After demounting, you can see I was able to get a decent amount of occlusion. After 6 months, the patient came back saying, once in a while I get headaches when I'm chewing, and he said somewhere occlusion is not happy. I'm not happy with the occlusion. So I decided to go ahead and check him with the T scan, and there was time. I felt there was time to do something called a DTR, which is disclosure time reduction. Whenever he does the lateral movements of the mandible, lateral excursions, there was some sort of friction which I identified with the T scan. So what is this T scan? T scan is a digital reading which I'll be explaining to you. And again, like I said, the readings showed between 3 to 4 in the masseters, 3.5 and 3.8, which I wasn't happy for. I wasn't happy with this. I wanted to get the masseter readings this lesser. So we have a protocol using the T scan. So basically, every time the patient bites on this electric sensor, it's like an articulating paper which has an electric field. You place it in the patient's mouth. Patient has to bite on it. You get a graph like this. It shows where exactly the high point or the interferences are. So we can also do this for lateral and anterior protrusive movements. So it shows us when, where, and how much of corrections are required. Many a times an articulating paper may show a very heavy point on a canine or the premolar, but on a digital paper, the part may not even be there, or the heavy high point may be in some other area. So most of the times, I don't know if we are actually doing the right thing by using articulating paper. So I do a disclosure and time reduction procedure using a digital technology with the T-scan. Since I have the EMGs, I can combine the same. How do I do that? I ask the patient to bite in centric first, tap, tap, tap. So I get a decent amount of bilaterally equal occlusion, but little heavy over that lower anteriors. You can see there 2-1 reason. So I slightly reduced that. And most of his bite was showing on the right side, which I corrected. The beauty of these EMGs, which I have, since I have them in my practice, when I ask the patient to disclude on the left side, move the lowers out to the left side with canine disclusion, I was able to see heavy readings on the temporalis. That means some obnoxious interference or noxious stimuli is causing the temporalis to fire every time the patient moves to the left or the right side. So I did the disclusion readings while checking the EMGs for this patient. And I found that whenever he discluded left, he was okay, because you can see left side was showing 98% of load, but a bit of interference on the right, somewhere in the 1617 region, which I corrected. Again, when I did right disclusion, it showed that heavy temporalis reading. So some amount of interferences was being projected in the T scan. So you can see when it is a right disclusion, there was a point on the left which was contacting and causing the temporalis to fire. So even a small interference is enough to cause muscles to fire like crazy. So corrections we have to do like how you do your high-speed rotor handpiece, but we use a very, very smooth or a round burr to do very, very, very minimal reduction. Post the correction, after I did my coronoplasty, I was able to get 100% movement, or rather 100% contact only on the canine. So now it is a canine guided disclusion or a canine guided occlusion. On the right side, there was a bit of attention on the right upper and lower canine. So I was getting more contact in the posteriors, but still you can see I was able to get 100% occlusion or disclusion on the right, the left side when I asked the patient to move to the right. So basically I have sort of balanced the left and right disclusion. At the same time, I checked my EMG, I was able to get all muscles, basically the temporalis, left and right, masseters, left and right to less than 2 or 2.5. So he reported after 7 to 14 days, he showed significant improvement in the occlusal change. He said my symptoms have come down and the frequency of headaches is almost 0. So this is how we can integrate a digital occlusal corrector with use of EMGs in our patients. Can I use this in a mixed dentition case? I did, and I got good results. So in most of the mixed dentition cases, I don't have to do it in all the patients. There are patients who complain. I get patients who are age of 6 to 10 years of age. They have a forward head posture. They have craniofacial pain on palpation of the masseter or the temporalis. They say they have a little bit of pain. especially when I ask the palpate the coronoid notch and ask the patient to open and close, they give TMJ pain. So such cases, one such girl came to my practice, and I'll just show you. But is it possible to do? Yes, we can apply the same philosophy in mixed condition cases. It's an effective tool to diagnose EMGs in young patients who present with TMJ pains or clicks. It is useful for determining whether the patient's jaw is growing in the myo trajectory. If you can start early, there's a chance that we can avoid orthodontic braces in many patients if it's growing in the right direction. Mandible is guided to grow in the myo trajectory or the myofacial position. The orthodontic treatment can be simplified or reduced. So this was a patient who was 9 years old. She didn't come with TMJ pain. She came with dental problems, saying my jaw is forward, but I palpated her craniofacial area and I was able to get a little bit of clicking, TMJ pain when I palpate the TMJ. She also gave history of bedwetting and migraines, mild OSA. So slightly narrow arches and oversight of more than 7 to 8 millimeters. Basically, whenever she opens big and close, she had issues in the TMJ area. So in her case, I used the K7 to record the bite. She was very cooperative. It's difficult to get cooperation for the K7 because it takes almost 1 to 2 hours to record the bite. So she was very cooperative. I did a jaw tracker for her, checked her EMGs, and even though her EMGs were fine, it showed that slightly she's off the myos trajectory. So in such situations, we record a bite and we send it to the lab. So in this case, I asked the lab to fabricate a Frankel's appliance. So this was her path of opening and closing, but when she was pulsing, the jaw wanted to come almost 2 millimeters forward, and she wanted to be in that path of closure. So you can see the mandible from there, it wanted to come there, and a vertical displacement of almost 3 boxes. One box is 1 millimeter, so 3 mm vertical and maybe 1 millimeter, 1.5 mm forward. So it's guiding us to say where the mandible wants to be for the muscles to be happy. It's called a neuromuscular trajectory. So with these scans and the bite, I sent it to the lab. The lab manufactured the FR2 appliance, and the patient was instructed to wear it most of the time, except while eating. So lips were quite incompetent in the initial phases, and later on, you can see is able to get some amount of mandibular anterior movement in 6 months. So it worked in her favor. She also said that her symptoms came down. Her bedwetting was little lesser. She was sleeping better. She had basically more energy when she wakes up. The parents weren't able to explain more than that. So severe reduction in symptoms, migraines improved. There was no clicking. So whenever I come across a patient, even if he's young, I make sure that I check her EMGs since I have the provision with me, and I make sure that I palpate the muscles. So in this seminar, I've actually not discussed about the diagnosis, palpation of muscles because it'll be too much. So basically, what I want is the patients to be asymptomatic, pain-free, and get the patient's jaw to grow in the physiologic trajectory. So basically, I was able to go from there to there. And then, of course, she may need a phase 2, maybe a twin block, maybe we can, but you can decide not to do orthodontic till a certain age. So I hope I was able to give you some sort of knowledge about how we can apply neuromuscular principles. And I'd just like to conclude by saying that to learn, you need to deprogram yourself first, just de-learn, you need to relearn, and then keep on learning. I thank Dr. Ajay and the panelists for giving me the opportunity to speak today. And like I said, we need a teamwork to handle such patients. It's not only the dentist which can help us. We are not just two doctors. Thank you.
Excellent presentation, Dr. Girish PV. It was so crisp, so crystal clear, and so to the point that it's sometimes we overlook all these problems, and we sometimes don't even know what the problem is. It's completely a new trajectory in the field of orthodontics. I personally have a few questions. Before I go ahead with the questions, there are more than 23 questions. Probably if you have a time, you can answer all those questions.
I will.
Okay. Let me just start by asking that when patient comes to us, sometimes it is very confusing whether patient is having a TMD, whether patient is having MPDS, or whether patient is having any other problem. So you have a broader terminology called neuromuscular orthodontics, which includes everything, whether it is MPDS, whether it is TMD, or whether it is a problem with the disc or any other problems, right? So how to diagnose, like straight away we have to put this patient under EMG at first go, or we have to do something like normally as an orthodontist we have been trained to do a functional examination. So can you just elaborate on that?
I got your question, sir. So basically, it's not possible that every clinician can invest in K7 and try to buy an EMG and incorporate in his practice. I was lucky and fortunate to have it. But most of my colleagues who are with me in this particular association we have, they have just the TENS unit. So with the TENS unit, they're able to manage 95% of their practice. But coming to a question of a patient who walks in the clinic, it's very important to understand first, what are you going to diagnose? What do you want to do? Is it within your realm of treatment? So none of us wants to lose any patient. So basically, I would first look at it from an ENT perspective. I would see if it's a growing patient, I mean, whether there are any tonsils, any adenoids. If the patient can afford to do a CBCT, that would be great. So the first thing would be to see if there's any emergency treatment that I need to do, which is of course the dental part of it. And if the patient is in severe pain, I would just give him a night guard without any measurement like you do, or just an anterior bite plane, which we were taught in RPG. Even my boss told me, give an anterior bite plane. Disocclude his posteriors is the philosophy. Every time you disocclude the posteriors, you're removing the abnormal stimuli from the teeth, which is irritating the muscles. So keep him disoccluded, then send him for whatever treatments he has to do, like an ENT, etc. Then once he comes back, if it is possible that you have the interest and you have the passion, you can invest in a TENS unit, which is why you need a TENS unit for 3D deprogramming. Like I said, the pitch, roll, and yaw has to be corrected. If I just do an anterior bite plane, I may not correct it in all the 3 dimensions. So
Okay.
some sort of infrastructure has to be done, like a TENS unit that would
Okay.
solve
As
most of
you,
the cases.
yeah, as you said, most of the cases you don't give retention, because most of them retention protocol, like here, because you are removing whatever the muscle problems are there, you are removing it. So you, most of the times you're putting your teeth in the balance zone, right?
Yes.
So you have a long-term follow-up of those cases where
Most patients are in the range of 1 to 2 years. That
okay.
patient whom I debonded, that was like 3 years patient, because it was just in 2016 that I started.
But you, if you follow your mentors
They have
things,
10-15 year follow-ups.
okay,
Dr.
great.
Fabio Savastano, who is there in the picture now, you can see.
Okay. Third question is about orthotic material. Whether it is like you have both the things, clear, acrylic, as well as tooth color. So you prefer it to be hard enough, or you prefer it to be with a soft liner inside, or
It has to
what?
be a hard split, sir.
Okay, it
It
has
has
to
to be
be.
a hard split, and if you notice, most of the orthotics were designed to look like teeth. That means there is a cusp, there is a slope, there is a fossa. So you're simulating the anatomy of the tooth. That is how the proprioception has to be. It has to be
La
anatomic.
okay.
But
Last
it
two
doesn't.
questions.
Just to complete that, it doesn't have to be tooth colored or clear. It's just the patient's choice.
Okay. Last two questions I
Yes,
have
sir.
personally.
Go ahead, sir. Go ahead.
One is about amount of extrusion you have shown was around 5 mm, 4 mm. So wouldn't it be, a problem for retention, first of all?
Till date, no, sir. I have even asked these questions to my gurus who have done, even in another case, which I haven't finished. I have an extrusion of almost 9 to 10 millimeters. And absolutely, the periodontium has followed it. I was worried where I will end up with a tooth with root exposure. But
Yes.
touch would not happen in any patient. We have
In no
done
altered sensation also, nothing.
absolutely nothing.
Okay. And the last questions, when you are extruding so much, like, and it is an uneven extrusion, and ultimately you get it, you are getting in the point where your muscles are in the best ever possible position. Now, when you are changing the, like when you are changing it, like when you are extruding it, there are chances that you are changing the occlusal plane also. And when you're changing the occlusal plane, there are chances that you might end up with a rotation of the mandible as well. So which might change the entire gamut of the other muscular activities. So every cases you do, at the end of the treatment, you always go for EMG and check whether all the things are perfect or not.
The second part I'll answer first. Every case I don't check the EMG. One reason being most of those electrodes, the stickers that we use are quite expensive unless the patient pays me. Second, in clinic, you know how it is. We cannot document all the cases, maybe like a PG institute. But I do in cases initially for me to have proof that what I'm doing is right. I did it for initial cases. Of late, I do only if the patient is symptomatic, like he still has pain, then I would want to check it. The first part, what is the question, sir? I'm sorry.
The question is about changing the
mandibular
occlusal
rotation.
Yes.
So basically, if you imagine the mandible, it is like a sling of, it is held in a sling of muscles. It's like you take a handkerchief, you take out the mandible and put it. So the mandible is controlled by a plethora of muscles. If I get all the muscles right, the mandible has to be in the desired position of the muscles. So I don't think the occlusal plane will matter in that situation.
Okay. Now we have a lot of questions, and meanwhile we have a very good panelist also here.
Yes,
Dr.
sir.
Reena ma'am, who herself is very proficient in this field. Then Dr. Mala ma'am is there. We have Dr. Mandava Prasad. I'll just go through question answer. Meanwhile, I would request panelists to have some words about this.
Is anybody else coming along, or should I speak first?
Yeah, ma'am. Reena ma'am, please go ahead.
Girish, it's been a fantastic presentation. Very nice and very exhaustive and impressive presentation. Very crisp, as Ajay said. You see, like as you rightly said, that every patient or every clinic is not going to be able to equip itself with very advanced gadgets. And yet we need to kind of work our way and look at TMD, dysfunction cases, into our realm. And we need to look into airway, we need to look into TMDs, we need to look into brux, sleep brux, and see the overlay, how it is and how it is affecting our patients. And at the end of it all, what we produce with orthodontics should be in line and in sync. So what do you think would be the role of trigger point examination? Because when one doesn't have this, at least to ascertain that. Number two, what I find in my cases where I am doing the PhDs quite regularly is that the muscle which causes a lot of issues for us is the medial pterygoid and the lateral pterygoid, and we have no way to reach it, but we have the trigger points on which I can work. So what do you feel about the role of the EMG? How far is it actually deep reaching and let's say assertive? For the masseter, for the temporalis, yes. Digastric, metalis, yes. But the two muscles, which are mainly the muscles, especially the lateral pterygoid and the medial pterygoid, what is your thinking about the EMG?
Thank you, ma'am, for being a panelist and first of all, coming here today. And regarding your question, yes, I know regarding any practitioner investing in all these equipments is not possible in every clinic, but with limited application of the TENS, I'm pretty sure many of them can help. Coming to the second part of the question, which is medial and lateral pterygoid, absolutely right. If there was some way I could place the electrode on medial pterygoid or lateral pterygoid, I would have an amazing reading. But since it's intraoral, I'm not able to place. So because of those restrictions, we have to use the masseter and temporalis, which is on the extraoral area. But the principle of TENS, if you observe, it is a bilaterally symmetrical pulsing electric pulse, which has been shown over decades of study by Dr. Jankelson that it not only deprograms the extraoral, but all the muscles supplied by the fifth and the seventh cranial nerve. So it is also deprogramming the medial pterygoid and lateral pterygoid. Only thing we are not able to measure it. In most patients, like I said, there's a overset of 7 mm, like a class 2 patient. I deprogram, I do a pre-EMG, I pre-scan of something called a scan 2 on the graph you saw. I get a scan of opening closure. I see an overset of 7 mm. But after tensing, again, when I check the same scan, the mandible has shifted forward. So it means that the lateral pterygoid, which was hypertonic, must have yielded, must have got deprogrammed to some extent. So at this point of time, there's no point of actually checking EMGs for lateral pterygoid, but I'm pretty sure that we're getting it deprogrammed during this treatment.
Thank you so much, Girish. But my question was about trigger points.
Trigger
Do you
points, yeah.
rely on trigger points?
I per se don't practice myself, but I work with a chiropractor who helps me with the trigger points. But in some patients who has a chief complaint of tinnitus, I'm pretty sure you also get many. We have plexus of something called pterygoid plexus in the sternocleidomastoid. So my teachers have told me that most of the trigger points. So trigger point is nothing but a taut band of muscle in certain muscles within the muscle which has to be relieved for the pain to go. And in most patients, the migraines that are coming, the trigger points lie in the sternocleidomastoid. I'm pretty sure you got many patients like that. So yes, I would do a trigger point release, but the whole point of this TENS therapy is that when I get the muscles to a position, or when I get the mandible to the position where the muscles are happy, all these pain should go away. So if they don't, then of course I would look at doing injections and trigger points, etc. But per se, it
I'm
is not fine.
Thank you, Girish, again, but I wasn't talking of trigger points as relieving the problem because I have full belief in TENS. I
Okay.
believe TENS is the way to go, but I was talking of the diagnosis part of it. So, there are many times that you want to differentiate because my understanding and my learning of orofacial pain is from Dr. Merrill. And what I understood was trigger points was a very vital part and also about posture.
Yes.
And I rely a lot on it, maybe because I do not have one of those advanced gadgets that you have, and my learning has been from there. So I was just wondering whether your experience before you procured this advanced machine, were you using any such thing for diagnosis, and how much difference did you find, if there was any? That's what I was trying to figure out. Nothing else. Otherwise, it's just great. I mean, I have no disbelief in TENS. In fact, I find TENS is a great machine. It's a beautiful thing because it really works well. And I'm sure TENS 5, J5 must be very good. Even though
Yes, ma'am.
personally I haven't worked with it. I have seen it. I haven't worked with it. Thank you so much.
Thank you, ma'am. Thank you.
I'll come back with another question, but I think I'd like to give the other panelists a chance. Otherwise, Ajay will say I'm hogging it.
No, ma'am. No, ma'am. No. The sole purpose of no, ma'am. The sole purpose of such webinar is mind storming only, nothing else.
Am I audible, Ajay?
Yes, Mala, ma'am, you are
Yeah,
audible.
okay. So basically, fantastic presentation, Dr. Girish.
Thank you.
And now I know where to send my patients from Bangalore. So now my major concern is about the amount of vertical that you increase. And have you related it to your freeway space and your and the muscle length?
Muscle length, as in
Yeah. The
overall.
existing length and the length that you are creating by increasing your vertical so much, and which
Okay.
in turn will definitely affect your retention. So this is what I am concerned about.
Okay. Okay. So basically, in most patients, if let's say we do 20 orthodontic treatments.
Sorry, I think there is
Some.
some. Okay.
Yeah.
Sorry.
In most orthodontic patients,
Yes.
suprareption won't be so much the extent of 8 mm, 10 mm. I just wanted to show where even if the vertical clearance of 7, 8 mm, I was able to get a good treatment. But most patients fall within the realm of or area of 3 to 4 millimeters or 2 to 3 millimeters.
Okay.
In those patients, yes, definitely they won't be relapse. In terms of the muscle length and the muscle, what do you say, the retention of the muscle fiber, we are treating the cause. What is the cause? The muscles are not happy in the current situation. What if I place the mandible? Like I said, the mandible is held in a sling of muscles. So all the muscles are tight. So if I release the mandible and the mandible chooses to be in this particular position, which is recorded to 1/10 of a millimeter precision in my software. So it is the body is telling me, the muscles are telling me, I'm happy in this point, put me in this point and I'll give you all the positives. So it's like we get the physiologic correction happening as soon as the patient start biting into that position. So whatever I said, the myotrajectory and the myocentric is the answer to all the muscular problems. And most of the TMJ are myogenesis in origin, like I said. And
Correct.
what was the other question you said now?
I was concerned about the freeway space.
Yeah, the freeway
You,
space. So there was something called a scan 5 where I showed the twitching and the
huh,
trajectory of the opening closing.
huh,
When I take the vertical height of the patient,
huh.
we reduce 1.5 mm and then we take the bite. So it's
Okay,
incorporated in our calculation.
okay,
So
okay.
it's not, we don't occupy the freeway space. If I get 5 mm
Have
of
you
clearance,
found a difference in the freeway space after your muscle toning?
0.1, 0.2 millimeters. Oh, maybe
Oh,
not much.
oh,
Never,
oh.
never, freeway spaces never happened. Like I said, when I do micro-obtusal corrections,
Huh.
sometimes I have found it that 0.1, 0.1, 0.2, 0.3 millimeters.
Okay,
That
okay.
also could
I-
be a cusp slope or a small ledge which
yeah,
happens.
yeah.
So, which is why I also showed a case where I used the T-scan to correct it.
Yes, yes.
It's never
See,
happened where a freeway space has been encroached upon, and
okay,
yeah,
okay.
never happened.
See, one more thing I wanted to ask you is, see, you kept saying that you do not give retention. But then, see, the retention is not only, the need for retention is not only because of the muscle forces, it is so many other things. So, how is it that you don't require retention in any of your cases? Is that what you were trying to say? I don't know
Yes,
if
ma'am.
I
True,
understood
true.
right.
I
Hmm.
correct, correct. So unfortunately, I don't have a 10-year follow because I've started practice like 3 to 4 years. But most of the
Okay.
patients who've
Huh,
been debonded in the last 3 years
huh,
have seen them periodically every 6 months.
huh.
I could share the data maybe in some other thing. Uh,
Okay.
Only in
So
one
you,
case, I think I had a minor spacing. Apart from
oh,
that, it's all perfect.
oh, so you don't give any kind of retention.
Nothing, nothing.
Okay,
It's
that's
not required. It's
fantastic.
not required.
That's very impressive.
Yes,
Very
ma'am.
impressive. Thank you, Dr. Girish.
Thank you,
Really great to hear from such a young person like you
ma'am.
who's going into new frontiers. Thank you.
Thank you, ma'am.
Very
Thank
a
you.
pleasure. And
Thank you.
thank you, Dr. Ajay, for giving me
Thank you,
this
ma'am.
opportunity.
Thank you, ma'am.
I-
Meanwhile, Dr. Mandava, you have anything to say?
Hello. Yeah, Jay. Yeah, good afternoon, Mala ma'am.
Good
So,
afternoon, Manda Prasad.
Girish. Yeah,
Yes, sir.
good afternoon, madam. Good afternoon. Nice. Girish, excellent presentation, Girish.
Thank you, sir.
So, what all questions I had, I think Ajay has read through my mind about the dental orthotics. Exactly, really. No, this is an excellent presentation. So crystal clear, electromyography simplified. It was really good. I always used to see that electromyography, what you have put that the graphs I had to see in the profit textbook. So that's what I was reminding, and it is so clear and so simplified. But as some of our panelists has told, Reena ma'am and all, Ajay has told also about the feasibility, and you should have special interest in this area.
Yes, sir.
What Ajay has told also same. The TMD cases, even we get little pop there. We get stuck there. The TMD cases are on the rise nowadays. I don't know, due to various reasons, maybe psychosocial factors or all these factors. So the TMD cases, the patient, the students especially, you take the medical and dental students, we have lots of cases. So we are little stuck there. Maximum we have in the college is the tents, as Reena ma'am was telling, the tents equipment, that's all. But these equipments, it has to be procured by the oral medicine or whatever. So overall, it was great, really. And the discussion, what I liked in this webinar, I think I attended the maximum webinars conducted by my brother Ajay Kubawat.
Thank you.
So the best part was the discussions, this question and answers and the discussion part, because this is only very useful. So
Yeah,
thank you very much. I will not take much time.
we
Girish,
we
Yes, sir. Thank
keep
you,
excellent,
sir.
Girish.
It's
we
an honor,
keep
sir.
this question and answer session mainly for because we have a lot of resident doctors who are attending our webinars.
Yes.
Right.
True.
So it's really a great opportunity for them to listen to young Turks like Girish and other speakers who came. Now we have certain questions from the audience. So can we take it?
Yes, sir. Go ahead. Go ahead.
Few of the questions are relevant only, and few already been answered. So I already answered 9 questions. So now Dr. Swapnil Pardes is asking about that if patient is vertical grower and he already has a gummy smile, and if you're extruding the anteriors, then what to do? Like in those cases, like he's little like, see, what is asking is what to do when incisor extrusion isn't indicated, especially in tooth or gummy smile. Comment on vertical asymmetric orthotic causing cant during verticalization. Effect of treatment on video and freeway space.
In terms of extrusion in a gummy smile, Touchwood never had a patient who's a vertical grower. Most of the TMJ patients, if you see even the literature, it's basically deep bite cases. Class 2 deep bite where the mandible is kind of, and of course, small maxilla, which has not allowed the mandible to grow to its full potential. So it's very rare that you will find a vertical grower with a TMJ case, and even class 3 patients. Very rare that you get a class 3 because mandible is already grown to its full potential. So most of these patients, even let us say you would have to do verticalization, it will probably be very less. But per se, my experience in this particular case is less. But I'm pretty sure if the muscles demand that you have to do it, I think that you'll have to look at it from relieving pain in the patient rather than looking at the aesthetics.
Okay.
Depends from case to case.
There's a question from Dr. Priyanka Parya. Sir, how to determine whether expansion is a provision for tongue space?
Again, it depends whether, like I said, the patients who has history of mild to moderate sleep apnea, there is the tongue is reduced, has a reduced volume of space. So most of these patients we check for the lateral tongue markings that are there, the teeth markings, indentations of the teeth on the side of the tongue. Of course, we also do a PSD3 or a polysomnography to see if the patient has sleep apnea. And if there is any amount of sleep apnea, even if it is 2 millimeters of expansion, I would still do it. It will help in some amount.
The same Dr. Priyanka Parya has a question that if patient is having a severe crowding in the upper arch, orthotic made after alignment done, or?
No, we go ahead and give the orthotic because our first objective is to relieve the pain, to make the patient asymptomatic. While the patient is wearing the orthotic, we can align the upper arch. Don't start supraeruption immediately.
Okay. Dr. Poonam Agarwal is asking about, do you consider growth pattern? You already mentioned.
Technically, no.
But you mentioned that most of the cases you coming through would be horizontal growth.
I wouldn't be handling or diagnosing my case based on the growth pattern. Is what I mean.
Okay. Somebody's asking, how do you decide if a patient requires expansion? You have answered it, right? Dr. Kishore Chogle asking, sir, do you encounter any stability problem? Same question has been answered. Anonymous attendees are, does this much stable extrusion? Again, same question. Retainer is okay, again, same question. Dr. A.V. Arun. Hi, Girish, excellent presentation. How much K7 and TENS apparatus cost? I think he has written cost, but it is cost us if we have to include in our practice. Very valid question.
Like I said, the K7 would be very expensive because I had to take a loan for my practice. So it costs somewhere in the range of like 25 lakhs plus.
Oh,
so
only K7 itself.
Yeah, so it's easier for an institution to buy the K7. The TENS, we have small TENS called smaller urate, which costs somewhere in the range of 1 to 2 lakhs.
Okay.
So it's not any other TENS, it's a patented machine, so it is a bit expensive.
Okay. Dr. Darshan Soda is asking, if patient have any periodontal problem, how to manage extrusion?
Most of these periodontal patients will have some sort of attrition and abfractions, which is caused because of sleep apnea. Most periodontists do not see the bruxism or the sleep or the attrition that is happening from a sleep apnea perspective, which is where, in fact, in today's topic, I could not combine a situation where most of the TMJ patients also had history of sleep apnea. So how to manage sleep apnea is a totally different seminar. So it depends on if the patient has a periodontal problem, of course, yes, you have to treat it first. But why is there periodontal problem? Is it because of clenching, night grinding, parafunctional habits, or is it because of systemic problem? So that has to be addressed first. If it is not because of systemic, if it is not because of any local parental factors, it has to be because of clenching during night or bruxism. That can be addressed with treatment for sleep apnea by wearing mandibular advancement devices, etc. But otherwise, management of parental problem has to be done. And of course, I wouldn't do orthodontic treatment in a phase 2. I would ask the patient to continue their orthotic itself for a long time.
Okay. There is a question from Dr. Mukesh. Sir, as given in Dawson, we make the orthotic in CR in the technique which we discussed. We give the orthotic in neuromuscular bite. Does this give orthopedic stability?
So basically, Dawson and all the principles that the prosthodontists use is all based on centric relation and centric occlusion. So that is a concept which doesn't consider the muscles at all. It's like you push like if you remember in a prosto during a BDS, the most posterior retrograde position of the mandible of the condyle is the centric relation and centric occlusion. So if I push the mandible backwards, the muscles are going to be further strained, the disc is going to get compressed. So as such, the neuromuscular concept that we follow cannot go hand in hand with the Dawson's or any other prosthodontic technique. It's totally based on its own philosophy. And we have got many documented studies about stability.
Okay. There is a question from Dr. Ipsit Trivedi. Does isotonic muscular position always coincide with the normal condylar position in glenoid fossa?
What is normal for one patient may not be normal for another patient. So there's a classification of condylar position by a person called Gelb. 1, 2, 3, etc., etc. There are 9 different positions. Sometimes a variation of 1 to 2 is not a big deal. So, but basically, in most of these TMJ patients, especially who has a click, the condyle is moved forward and it is compressing. The disc is locked. It's called TMJ dislocation with reduction and without reduction. So in all those patients, you'll see that the disc is out of position. So if I can get my mandible and especially the condyle to a good position where the disc is recaptured, it need not be in the center. It can be sometimes off center, sometimes superior or inferior. So it's all based on the muscles rather than looking at the condylar position.
Okay. The same Dr. Ipsit Trivedi is asking about whether the orthotic fabricated from heat cure resin or a cold cure.
Heat cure is better because it's more durable. Because a cold cure is a lot of shrinkage. So we have tried in-house and a lot of shrinkage, it doesn't fit. Heat cure is better.
We have one participant from Dhaka. He wants to ask Dr. Mohammad Anisur Rahman. Go ahead, doctor.
Thank you, sir, for the excellent presentation, sir. My
Hi,
question
Dr.
is,
Mohammed.
yes, if the patient have some previous kind of TMJ problem, like some degenerative changes or some tumor, in that case, how do you should you exclude those at first?
You mean to ask pathological issues?
Yeah.
Okay.
Any tumor or any joint, maybe attrition or for the condyle which has been shaved off, or any osteogenic problem or any resorption in the bone, is mostly muscular. But if it's pathologic like a tumor or a cyst, that has to be handled by a surgeon at home.
Okay. So do you advise MRI in certain cases to rule out any pathological things if you?
We would love to do an MRI for all the patients.
But
the problem is
expensive.
The problem is, one is the cost. Second, the patients tell me I have to sit in that tunnel for 45 minutes.
I know.
Revolving around me.
It's horrible.
But,
I know that.
Yeah, but that's only for a diagnostic perspective. But we usually go by the symptoms. We do a CBCT.
Okay. Thank you. Yeah. Okay. Now, Dr. Ankur Agarwal is asking, sir, any scan to track activity of lateral pterygoid muscle?
As such, we can't place a deotrode, like I said, on lateral remedial pterygoid. We would love to do it. But one of my friend who is a radiologist in Cochin, he tracks the amount of bone elongation, the pterygoid plate, which is the lateral pterygoid plate. If you know, the lateral pterygoid muscle inserts from there to the condyle. So he's doing a study basically where he does a preoperative CBCT scan. In one of the slices, he studies the length of the lateral pterygoid plate. And then post-treatment, after 2-3 years, he's doing a study. I'm pretty sure that will be published in future. So it shows that the shortening of the lateral pterygoid plate, because the muscles are inserted there, is causing a stress, which is causing resorption of the lateral gut plate. So if there would be some sort of way of tracking it with an EMG, that would be wonderful.
Okay.
Right now, it's only radiological.
Okay, Dr. Hemadri Srirangam is asking, sir, pre-treatment and post-treatment T-scan is necessary in TMD cases?
No, I just wanted to show you that how we can apply a simple tool to show that I have seen orthodontists do enameloplasty just to balance occlusion. I have two advices for them. This is my experience, not to offend any seniors. Doing any occlusal correction with articulating paper, please wait for a year till the occlusion stabilizes, unless you want to do any plunger cusp reduction or any cusp or slope. Secondly, if you have a T-scan, you can do it right away, because you are actually not doing it any wrong place. You know that the digital reading that comes. So that is my suggestion. It is not necessary in all patients. Only if like it's basically to correct micro occlusion.
Okay. Dr. Roshan Sagarkar is asking, sir, a very interesting presentation. My question is how to manage extraction cases. Space closure first followed by settling the occlusion or vice versa?
So from last maybe 6 years, I haven't done an extraction case, because most of my gurus have told me that extraction or retractive orthodontics is not good for TMJ sleep apnea. At the same time, touch wood, none of my extraction cases which I have done previously have come back with any TMJ problem, or I don't know if they have gone to others. But the principle of neuromuscular principle, especially if a patient is sleep apnea, who has mild sleep apnea, who has reduced tongue space, we don't advise extraction.
So I would say that most of the times, non-growing patient would be a mutilated case or a secondary patient referred by somebody, or because of some secondary problem he has developed, or because in growing patient you had shown one girl, right, in whom you could diagnose the OSA along with the bedwetting and a lot of other things, and you did give up Frankel, and it gave good result. But in adult patient, I think most of the time either they have undergone the orthodontic treatment or some other sort of treatment. So all those are the secondary patients.
In those cases, first
mutilated cases.
Yeah, in those cases, first I would see. Let's assume it's a bicuspid extraction case. If he's asymptomatic, of course, I wouldn't do anything. But if he's got pain, if I do a sleep study, I do a CBCT, I check his airway. In the sleep study, if he shows that he's got obstructive sleep apnea, which and his AHI is more than 5, sometimes 15 to 20, I have to open the extraction spaces. I have to give back his tongue space. And the moment I open his tongue spaces, his sleep improves and his symptoms go away. It's so like magic, it works.
Okay. Dr. Bharvi Jani is asking, has 3-piece corrector any advantages over traditional full coverage splint?
3-piece meaning 3 separate pieces, he's asking?
I don't know. If
No,
she's there, she can ask. Let me check whether she is there. Yeah,
anyways, I'll ask her.
No, let her.
Okay.
Dr. Bharvi, you're allowed to speak. Please talk and ask.
So my question is 3-piece correct? I mean 2 posterior splint and 1 anterior splint like Lucia jig, in which the posterior splint are worn only during the night time, and in the daytime they wear the anterior splint. So is that useful over anything over the full coverage?
So basically anything which causes disocclusion, like I said, helps the patient. But let's say you give a Lucia jig in the anteriors, many a times the pain will come down, and then the patient is going to come back with pain, because you corrected only one aspect, like I said, the pitch roll or the other yaw. So, but how long will the patient wear it? But in your question, if you're comparing 3-piece and full coverage, I would say in a day full coverage, because in a full coverage, I'm not only giving him just occlusion, I'm also checking excursive movements, I'm doing anterior protrusive, I'm keeping the whole jaw in a stable position. In it, I would prefer a full coverage.
Thank you.
Thank you, sir.
Thank you. Okay, there's a question from Dr. Pankaj Kumar Parikh. Can you please tell us about ICCMO in brief?
Okay. Thank you, Pankaj. So basically, ICCMO is an organization which is based in the US. It's called International College of Craniomandibular Orthopedics. So you could just log in to iccmo.org. Anyone wants to learn about this, or you can see my email and number. You can always shoot some questions if you want any help. I can always help you. So icmo.org, iccmo.org. It's a 30-year-old, maybe 40-year-old organization. So they focus on TMJ, sleep apnea, and like I said, CCMD, all these aspects. So we started the international, we got the license from ICMO to start ICMO India in 2017. And we are trying to get doctors to understand the concepts of neuromuscular. You can get in touch with me if you want to learn more about this.
Okay. Right. Okay. I think Dr. Sanjay Kumar has a question. Dr. Sanjay, please go ahead. Dr.
Yeah,
Sanjay.
hi.
Hi,
Yeah.
Sanjay.
Hi, Girish, can you hear me?
Yes, sir. Go ahead.
Yeah, it's excellent presentation. I had a doubt. Since you are settling the, extruding the molars or undersized wire, and the chances that, right or left can extrude more. So I'm thinking, is it there a chance to incorporate Cantor occlusion?
So basically, like I said, it'll never be equal on left and right. In most of your patients, like I said, super eruption on one side is 3 millimeters, other side is 4, because that is where the muscles want to be. I have to do, if you observe the undersized wire in the upper jaw was only the initial period, but as I did leveling and everything, I go full slot. I got 21-25 stainless steel. So by end of 6 months, my upper jaw would have been in 21-25 stainless steel. I would have lost some amount of anchorage in terms of vertical, but my ultimate goal is to contact both upper and lower into the occlusion that the muscles wanted to be. So never had. So I'm pretty sure that in some cases the occlusal cant is there, but you will have to. This protocol says that you have to treat the muscles, the pain. So, but it's never
Girish?
happened. Yeah, yes, ma'am.
Sanjay, hi Sanjay. See, Girish,
Hi, ma'am.
what I was, what I was thinking about
Yes,
is that look at your jaw tracker. Even though we are not placing EMG leads, any of these places of the muscles, which I asked you, which even he's asking, is the lateral and the medial pterygoid. But the very fact that you have a grid, which is telling you how much you have to move it laterally and how much you have to move it anteriorly. So your yaw and roll is being managed. Now the yaw and roll comes from which muscle? It's basically the muscle is your lateral and medial pterygoid. It's your pitch, which is your closing muscles, So I think it's pretty well calibrated. And I don't think we should be getting any kind of a cant, except my only worry is that many of the cases, actually 2 of them I saw that the second molar, if you remember the first case of yours, the second molar was, as you said, I did nothing with the second molar, but it just touched. Because I believe that the premature contact probably was at the second molar.
Before treatment.
And the first contact was probably at the second molar. And hence, when you open the bite, even though it was opening about 6 millimeters in the rest of the areas, but the tripoding came at the second molar very early. It came in very early. So
wedge effect.
Yes,
Yes,
yes. Your
yes.
tripoding came in very early in the second molar.
Yes.
So I think maybe what Sanjay is also saying is that, Sanjay, just tell me if I think we can discuss this out. Probably we need to look at our patients to see whether there is an overhang of the palatal cusp, whether there is a, our talk, buccolingual talk is okay or not. And the other thing is about seeing whether we need to intrude a little in that area, probably, or upright in that area first, and then probably extrude, even if we need to extrude, as you say that. But I do believe that the cant should not happen unless we have not taken care of the hanging cusp or the rolled in molars. What do you say, Ajay, Sanjay? What do you say? And Girish.
Ma'am, I agree with you, because most of the times it generally wouldn't be a problem in such cases. And as you rightly said, there is an uneven extrusion, but there are chances of uneven problems also, as he has rightly mentioned. I think Girish has mentioned in his lecture also that sometimes on a right side you need 3 mm and left side you might need a 5 mm of extrusion. Right, because there was a problem there, and that was causing a TMD. So I guess
and Girish is, I think, using cable mechanics. He's using elastics on the lingual as well as on the
lingual also.
Yes, I saw that. So I think he's taking care of it. So that's a very good thing. That's really good.
Thank you, ma'am. Okay, there is a question from Dr. Sejian Max. For the third molar extraction, if patients still having TMJ pain due to prolonged mouth opening, initially can be managed by analgesics and MR, But even on long term, if the pain still persists, can this TENS treatment help in relieving the pain, and how to go about it?
Absolutely. TENS is not only for ortho or prosthodontic, it's any patient who's in pain, any patients who need the muscles to become from hypertonic to isotonic. So it's also used. In fact, we have TENS machines. It's called BNS40. It's a smaller version. I think many patients in the US, because it's manufactured there, they use it at home to relieve the TMJ pain because the cost of treatment there is so high that patients buy these home TENS and they do it. So in many patients, like I said in my practice, you asked me a question of third molar. The mouth opening is so less. I just TENS the patient, give a small splint like an anterior bite pain. I don't do any treatment, and the mouth opening improves in by the subsequent appointment. So it can be absolutely used in all these patients.
Okay. Dr. Darshan Soda is asking, changing in occlusion plan can lead to extraoral changes. I think we have already discussed, Dr. Darshan, about it. Ipsit Trivedi, TMDs have a wide array of etiologies, including internal disc derangement with or without reduction. Do you suggest to go in the same way to treat this too?
Like Dr. Ajay was also mentioning, if the etiology is a pathology, that's a totally different ballgame. But if it's due to malposition of the jaw, malposition of the condyle and muscular imbalance, all of this will be taken care of in 3D with the TENS and the protocol that I suggested.
Okay. Okay, Dr. Madhusudan is asking, in case of skeletal deep bite, how feasible is opening the bite?
In fact, patients who has deep bite, it works very well because you're actually supraerupting and causing the posterior supraerupt. The bite is automatically opening arteries. It works very well. It works amazingly. And most of the TMJ patients, 70 to 80% come in that aspect of deep bite because the mandible is trapped.
Right. Dr. Jatan Sanghvi is asking, no retention even in median diastema or class 2 division 2 cases. Dr. Jatan, I hope you are, mixing here a classical orthodontics with the TMD orthodontics. All the cases he is not treating, and he's not, it is not that, if whatever I understood is that in cases where neuromuscular orthodontics has been practiced, in those cases he is not giving retention, if I'm
correct sir, correct.
Right. Okay,
All patients who come, I don't do EMGs and scans.
Right.
If I feel they need treatment for TMJ or sleep apnea, then only I take them to neuromuscular.
Okay, because most of them understood that you don't
understood.
give retention in every cases. Dr. Vivek, yeah, tell me.
But I would just like to add, saying, let's say there's a case of spacing, and let's say that I have patient who had had undergone spacing treatment, but even after many years of wearing retainers, a retainer broke, the spacing just came back. So in that case, we have to rule out whether it's macroglossia, whether the arch is narrow, whether there's a muscular imbalance. I would probably take such a case, give arch expansion in neuromuscular way, and then I wouldn't do a retainer. Because you have to eliminate the tongue forces and the buccinator forces.
Okay, Dr. Vivek Reddy is asking, good evening, sir. Can I know the company and cost of the he has already mentioned. Company, I don't know.
Company is Myotronics.
What about TENS? You didn't mention about
same
TENS.
thing, same company.
What is the cost of TENS?
A small TENS is around 1 lakh. The bigger one is around 2.5.
So this physiotherapists do have it, right? Same kind of.
They don't. Nobody has the TMJ. Only it has to go through the ECMO. It's patented for TMJ.
Okay.
What the physiotherapists use is not bilaterally. It's not patented for TMJ.
Okay. So Jojo Joseph is asking, thank you so much for fantastic presentation, Girish. What's your opinion about FRLA? Lower arch.
Usually, if you see most of these patients, the lowers are lingually tipped, the lower molars. So most of my uprighting will happen just with the archware. So FRLA, I would just give it for 1 or 2 months just to overcompensate sometimes and match the upper expansion.
Okay. Dr. Anita is asking about, I think, acrylic. He is making from acrylic what he said, no? That it is from acrylic only. The splint or orthotic. Swapnil Pardes is asking, please comment on cant in asymmetric orthotic activation. I think we have already mentioned just now also. Okay, Dr. Luke John is asking, sir, extraordinary webinar. I have few practical issues. How to motivate a patient regarding this setup, as it is bit technique sensitive, and what would be the price of, okay, setup, he has already mentioned what is the cost of the setup. But now how to motivate, I think Dr. Girish would be a better person to answer on that.
How to motivate is first to motivate yourself, whether you have the passion to go in this direction. So it depends on your personal interest, sir. But I think you will not look back once you go in.
I think, Girish, the answer would be quality of life. If it is affecting the
Exactly.
quality of life of the patient will be motivated to do anything new. But if it is not interfering with his quality of life, health-related quality of life, social quality of life, I think that should be the most important factor to communicate and talk to the patient.
I think he also means investment in his clinic. So
And
Exactly. Rina
Yeah,
madam. Hello, Rina
Yeah,
madam. Exactly, madam. The current paradigm shift is our oral health related quality of life. So if you can really motivate the
True.
patient, that will be very, very useful.
And I would tell you that only TMD patients know that how much pain they are going through. And
True.
if you relieve their pain, and if you are really, if they are well-to-do, mind my word, mark my words rather, I would say, they'll give you endless money. You ask for it and they'll definitely pay for it, right? Because TMD is something which no one can tolerate. It is excruciating pain, and it bothers you day in and day out. It's not that well you sleeping, like when you get up you're tired, something like what OS, and this is all together, I guess. Okay, Luke John, same question, I think. Okay, Dr. Sridhar Kodumuru, is the orthotic appliance to be worn continuous or can be removed during eating of food? Will they cause any alteration?
absolutely not. It has to be worn because that is your teeth. You change the mandibular, the way you're closing and chewing, you change occlusal position. So the patient removes only for brushing, nothing else. He has to eat on that.
Okay, Dr. Madhusudan is asking, last question. Any suggestions for orthodontic surgical cases during construction of splint?
Two different ball games, so I wouldn't mix it. But there are cases who come to our clinic who had condylectomy, and we have done TENS, and we have given them. We haven't done orthodontics. We have done the phase 2 reconstruction, and they're feeling better.
Okay, the
It's
last
totally
question.
two different.
Last question by Dr. Prasad Borole. Patient complaining clicking. He has a history of ortho treatment with upper 4 extractions. What will be the cause and treatment of TMJ? That's a very vague question, but that's fine. Let him.
Upper 4 extractions, TMJ patient.
And clicking noise.
Okay, so it's important that you take a proper history, find out whether he had a clicking even before the ortho treatment, or he got the clicking during or after the ortho treatment. One thing. Second, rule out his obstructive sleep apnea, whether he's got any clenching, sleep apnea episodes, how much is AHI, rule out all those things. See for attrition, fractions. If there is a sleep apnea, that means the tongue is cramped for space. Any expansion of the arch, you have to open up the spaces, and you will see a tremendous improvement in the patient.
I think Dr. Prasad is there. Let him speak so that if he has any specific chief complaint by the patient, we'll be able to answer it better.
Yes,
Dr. Prasad.
okay.
Just a minute. Yeah, Dr. Prasad, can you hear me? If you can talk. I guess he's not able to. Anyways, thank you so much, Dr. Girish. Thank you so much, panelists, Reena ma'am, Mala ma'am, Dr. Mandava, and thank you so much all the audience who stayed here for such a long time. And it's a pleasure for me to host such a webinars, which I think must be useful for all of you guys, right? Please.
It's a wonderful session, Ajay.
Thank you. Thank you. All
Thank
of you.
you.
Thank you,
Ajay. Thank you, Girish.
Thank you very much.
All of you stay safe. Bye.
Thank you so much, Ajay. Thank you.
Thank you for the opportunity, sir.
And
Thank you.